Welcome to our Meet the Quadruple Aim with Peer Specialists webinar. So excited to have you here to kick off our upcoming learning series and share with you what we're seeing and working on and how we can all work together to make sure as many people as possible and who want it get access to the transformational service of peer support. This will be a short introduction to some of the major issues as we see it and we have seen in the research with some solutions, and then a description of some of the upcoming more intensive learning sessions that we'll have next month. A recording and the slides will also be made available after the webinar, and if you have any questions throughout, please enter them in the chat box and we can address them at the end of the presentation. So to give an introduction, so my name's Kelly Davis. I'm the Director of Peer Advocacy Supports and Services at MHA. I'm super passionate about transforming how we support individuals and change systems and services based on my lived experience with mental health challenges and trauma. I work at MHA on peer support, peer certification, youth and young adult leadership, and college mental health. And I'm passionate about trauma-informed care, peer support, consumer-led transformation, positive psychology, and civil rights. And I'm joined today by Patrick Hendry. And Patrick is the Vice President of Peer Advocacy, Supports, and Services at MHA. He's worked as a mental health advocate for the past 24 years. His areas of expertise include peer-provided services, self-directed care, recovery-based training, organizational development, and management and sustainability. Patrick received MHA's highest honor, Clifford W. Beers Award in 2012, and a Sample Voice Award, and Eli Lilly Reinspiration Lifetime Achievement Award in 2014. He's the former executive director of the Florida Peer Network and has assisted in the development of numerous peer run programs and organizations. Patrick is a strong supporter of the inclusion of mental health consumers in all aspects of the behavioral health system. So an overview of what we'll be covering today. So we'll discuss where we are now, what isn't working, what are peers and how do they help, barriers to the expansion of peer support, and then some solutions we have to expand peer support and improve mental health outcomes. Are folks able to hear me better now? I saw in the comments it sounded a little muffled. Awesome. Okay, great. So, perfect. Okay, move very close to the laptop. Thanks for letting me know. So, where are we now? So many of us have, we work in this field. We've been paying attention to the news. We're seeing increases in suicide and drug-related deaths. The life expectancy rate in the U.S. has gone down. We're also seeing increased awareness and demand for services. So more and more people are aware of mental health issues and are looking for help. And the way that we deal with mental health and address mental health now is often triggered by crisis. So MHA, as a national organization, has a guiding philosophy of before stage 4. And that's the idea that mental health conditions are the only health conditions that, as a matter of public policy, we wait until stage 4 or crisis to support and address. And that's how many folks get involved in the mental health system and mental health services, is later on when they're really not doing well, even if they've looked for support before. We're also seeing a behavioral health workforce shortage. So in many parts of the country, when people are looking for supports and services, there aren't providers in their area to meet their needs, or there's long wait times, or they otherwise can't access care. The same is true, we're waiting for full mental health parity. So many folks who do want access to services are being denied unfairly access to the resources that would help them and support their mental health. So that's another large issue that we're working on across the country. For people who do get access to services and supports, they often don't engage with or stay engaged with services. So folks are referred to resources, but there's a lack of either connection to the next resource that would be available to them. So for example, if I ask for support in my primary care office, I don't necessarily receive support in making the next connection, and many people who are referred for mental health services don't end up actually getting linked up into services even when they are available to them. Or there's a large number of people who, for many different reasons, don't stay engaged with their services. And the last piece is a lack of consistent outcomes and improvements for individuals receiving support. So we see a large degree of quality in services that are provided too. So what isn't working? So obviously the lack of providers and engagement strategies. So we don't have enough people to support those who want help, and we don't do a great job bringing those who would benefit in either. We have inconsistent supports and outcomes, as I mentioned before. So different degrees of what people get when they ask for support and how it impacts their lives. We're not comprehensive in meeting people's needs. So it's not just about access to medication if people want it, and it's not just about access to symptom management or, whatever is a crisis in someone's life, but we're not treating and supporting people in a more comprehensive way. So whether that's their social needs, their transportation needs, or any number of things that we know really makes an impact for people's well-being. And finally, a lot of what we do is not informed by the voices of lived experience. So for the people who have had access to services, and who have improved and who are in recovery, we're not necessarily taking their ideas and experiences into account when we change the way we provide services or thinking about maybe moving more broadly into what has made the biggest difference for the people who have benefited from formal or informal systems and services. And in terms of payment, so we also have an old paradigm of paying for things as they happen that doesn't consider overall costs and goals. So when people receive services, as I mentioned before, a lot of times they end up in crisis. And we spend a lot on the most expensive levels of care that don't incentivize improvement in well-being, self-management, and empowerment. It's really about paying for things as people get access to them and not thinking more broadly. So we're not thinking about it, and we're also not paying for services that way either. And these are all big problems that we see peers as being part of the solution to addressing. And more broadly in healthcare, there's this shift towards the quadruple aim of healthcare reform. So leaders in the field recognize how expensive and ineffective this strategy is in all healthcare, not just mental health. So this new focus is on the quadruple aim as the goal of healthcare improvement. So we want to improve the patient experience or the person's experience, population health, reduction of costs, and the care team well-being. And what that means is that we want better outcomes for the individuals seeking support. We want healthier people overall. We want reduced costs for when people do access services. And we also want to consider the care of those who are providing services. So there's a lot of, with the behavioral health workforce shortage and a lot of demands we put on providers, we also want to make sure we have a healthy and engaged workforce too. So I'll turn it over to Patrick to talk a little bit about what peers are and how we see them fitting into solving many of these issues.
Thanks, Kelly. Yes.
There you go. Great.
Okay. I just wanted to start off and say thank you for bringing me on the webinar. And also I wanted to mention that I'm getting over something, so my voice is a little rough, and I may cough from time to time, but I apologize. So the first thing we want to look at is not everyone attending this webinar is tremendously familiar with what peer support is and what peer specialists do. Peer specialists or recovery specialists or peer support specialists, or all of the varieties of names that we use for this type of work, are individuals with specialized training and work experience that really supplements personal lived experience. In other words, people who have lived with psychiatric diagnoses, who had to navigate a system of care, have, faced the kinds of problems, social problems that everyone who is diagnosed eventually does face, and the type of losses that we experience. And then they also help other people on their road to recovery in a holistic manner. Slide, please. So let's talk a little bit about how we got to where we are in peer support. And so it's really the modern age of peer support we're going to talk about. And the basis for it is really back in the 70s and maybe even the 60s. And in the 60s and 70s, we went through a very long period of social change in this country, and a lot of it was based around civil rights and human rights. So hospital systems and state governments had found out that the large psychiatric hospital system that was set up around this country, that at one point had over 550,000 people as patients within these hospitals. It's now down to about 50 to 55,000, and it's still too much. But at that point, they began to let people out of the hospitals. The problem was they didn't provide them with the supports and the access to services in the communities that they needed. And the other big problem was that many of these people had been treated horrendously by a system, and they were angry, and many of them referred to themselves as survivors or ex-patients. And when they said survivor, they didn't mean they survived their illness. They meant that they survived the experience of being in that system of care. So people began to come out, and they began to meet in small groups around the country. There was a lot of stuff going on the West Coast and the Northeast Coast of the United States. People met together on college campuses and in people's homes, and they began a self-help movement, which eventually kind of morphed into this peer support movement that we have now today. In the 1980s, some of the folks who had kind of withdrawn from the system of care, wanted nothing to do with psychiatry, wanted nothing to do with the behavioral health system, began to realize that if it was ever going to get better for anyone, then somebody needed to work from the inside. And so this began what we call the consumer movement. And consumers began working as paid and voluntary workers in the public behavioral health system to provide peer support. And it was, in the beginning, the roles were very minimal. Not much attention was paid to peer support at that time, but it quickly proved to be valuable. In 1999, Georgia's Medicaid Authority became the first Medicaid group in the country that allowed distribution of Medicaid funds for peer support. And that was followed up quickly in 2001 when Georgia created the first state peer certification. Moving forward into 2007, the Center for Mental Health Services, Center for Medicaid and Medicare and Medicaid Services declared peer support an evidence-based practice. And this made a tremendous amount of difference because now states were able to define for themselves more readily what was a reimbursable service under Medicaid law. And then we move to today, and the vast majority of states now have state certification. And most states have Medicaid reimbursement for some types of peer specialist work. That's still expanding. I think we have 42 states now that accept, that will pay for peer support with Medicaid funds. But eventually, I think it will be throughout. And then there's other avenues for paying for peer support too. A number of states still are on a fee-for-service basis. Sometimes peer services are paid for through general revenue or tax dollars. Next slide, please. So let's talk about what peers actually do. We know that peers do support. They can provide direct support. They can run support groups. They can work on programs that provide all kinds of social supports within the system. But support is probably the key word in the whole idea of peer specialists and peer support. They also model recovery, and they model the ability to step back into the workforce, because the folks who are involved in these systems of care have gone through the same experiences as the people that they wish to help. And so now as they come from being in recovery themselves, begin to feel strong enough, decide that it's time for them and a possibility for them to give back to the system, they become models for the next group of people coming along. So peer support is moving people from disability to ability. And that's a very important concept. Another key part, and maybe where we first started in the consumer movement, was peers working as navigators within the healthcare system. And that's because these people had been through the system themselves. They've seen all of the barriers that we face and the ways to work around problems that come up day to day. And so they are very helpful in helping people to learn how to work their way through what is really a very fractured system of care. Peer support workers are teachers. They teach health skills. They teach self-management and goal setting and self-advocacy skills. And all of those things are really, really very critical. Self-management is probably the key for most people to recovery. You know, we've talked for many years about person-centered care, and to some people it means, you know, where the individual really is at the center of their own treatment plan and care. But some agencies have taken this just as lip service. And so even though you might have a treatment plan that you sign off on, it doesn't necessarily mean that you were the one that created it. When you become a self-manager and you start to take an active role in your own care and you begin to work in partnership with your providers, all of a sudden you have a vested interest in staying with that plan that you've created. And this comes out with much better outcomes for people. And then finally, we're connectors. We connect people to the community. We connect people to the types of supports that everyone needs, like housing and transportation and access to services and connections to social life in the community, and even ways of learning to find your place in a community that may be inclined to kind of push us to the margins. According to SAMHSA, they may also plan and develop groups and services or activities, supervise other peer workers, provide training, gather information on resources, administer programs or agencies, educate the public and policymakers, and work to raise awareness. And what this really means is that peers can play virtually any role in the mental health system. And one of the things that when Kelly's voice went out, her audio went out for a minute, she mentioned is that I'm a firm believer that peers should be involved at every single level of the behavioral health system. And so people can come in and maybe their initial role is working as a peer specialist in a community mental health center. They may go on to run a program or become a supervisor or become a trainer, but they may also go on to become administrators. They may run their own organizations, and some have become CEOs of very large organizations. Next slide, please. So where can you find peer support? It's getting to a place, at least in the public system, where you can find it almost anywhere if you look hard enough. Peers can be found across all kinds of settings, in inpatient services, so in long and short-term inpatient stays, emergency departments, peer-run respites, community mental health centers, peer-run organizations, phone-based peer support, jails and prisons, and pretty much any place else that you can think of where peer support can be valuable. Next slide, please. So this is part of a chart that was done by Pat Deegan, and Pat is a peer, but she's also a very renowned researcher in behavioral health and has done a lot of the really core work on the concepts of shared decision-making. In this particular chart, these are just a few excerpts from it, she compares the peer specialist perspective to the clinical perspective and then where they overlap. So for instance, work in the peer specialist perspective is guided by the principle of mutuality, defining as a focus on the connectiveness between the peer specialist and the person who's receiving the services, and it's done with the reciprocity. This really goes back to what is known widely and for many, many years as the helper principle. We know that when we help others, we also help ourselves. Very often the person who is in the helping role may even gain more than the person who's receiving the services. From the clinical perspective, clinicians are in the role of helping and supporting participants with a focus on diagnosis, identification of strengths and treatments. There's no expectation of reciprocity or mutuality in a clinician-participant kind of relationship. But the overlap is that both of them have an unconditional regard for the individual being served, and they just come at it from two different directions. And that's why it's so incredibly important that we share that knowledge and we work in a partnership way with our providers if that's the route that we choose to take in our lives. Another area is that in the peer perspective, we focus on learning together rather than assessing or prescribing help. We look at a person's needs, we look at a person's goals, we help them to identify those goals, and then we help them to find the solutions to those goals. On the clinical side, they focus on assessing and helping, but the help is done more in a way of providing with resources or providing with specific tools as opposed to investigating these concepts as a team together. The overlap is a desire to support recovery and the person's achievement of their human potential, and that's really what recovery is all about. And then the third point in this very shortened version of Pat's chart is that peers don't participate in the delivery of involuntary interventions, such as commitment to a hospital or outpatient commitment, or even trying to get people to take medications or to go into any particular type of treatment. Clinician looks at involuntary interventions, such as commitment to a hospital, that it can be justified as a clinician's struggle to balance the duty to care and the dignity of risk. And those two things are very, very hard to walk a line between, because as a professional, there is a duty to care for a person to the best of your ability and to do no harm. At the same time, people should be allowed to take chances. We learn as much by the things that don't work for us as we do by the things that do. So both clinicians and peers recognize the importance of choice and self-determination in the recovery process. Next slide, please. So what is the impact of peers on the system and on the individuals? Well, we'll look at it a bit more closely, but basically we see improved outcomes, and there are more and more studies coming out all the time showing the types of outcomes that we can expect from the different models of peer support. We also see a reduction in costs, and that's because of what Kelly mentioned earlier. You know, as we keep people out of the deep end of services, inpatient settings, emergency room uses, crisis stays, those are the most expensive type of services possible, and they come very late in the process, so people don't even have the opportunity to benefit from them as much as possible. If we can meet people's needs early on and understand what they want in their lives and then help them to achieve that, we not only provide them with better outcomes and a better quality of life, but we also reduce costs. And when we reduce costs, it means that more people can have access to services. We look at healthier populations. You know, for a long time now, we've been talking about the social determinants of care, and for a while the peer community has kind of discussed back and forth, what are our roles in changing the social determinants of care? And one of the things that we can do is by showing the example of people, most people will tend to recover to some degree in their life. And that's with or without treatment. Doesn't mean that it's 100% for any single group in any direction. But as we begin to touch people at the earliest possible time, and to provide them with the type of human supports that they need in the system, then we start to see changes in society. Not only changes in the fact that maybe fewer people end up in deep end services, but also that society views mental health conditions in a much less negative frame. And finally, we create happier providers. And that's important too, because when providers feel like they're really accomplishing something, then they're motivated to do even better. And that's what we want from a system of care. Next slide, please. So we can talk about the impact of peers. So we talked about improved outcomes. The number one outcome that we look for usually in peer support is an improved quality of life. I mean, that's what every single individual wants. And if we're providing services and people's lives are not getting better, then we're not doing it right. We look for decreased depression and substance use throughout society. We look for an increase in hope, not only of the people who are receiving services and who are living with the barriers and problems that arise from having a diagnosis or having a certain set of symptoms, but also increased hope in families, increased hope in the system, that we're headed in a proper direction. So peers have really been the primary change agent, I think, in the last 15 to 20 years in behavioral health, in that peers came into this system and they humanized it. And they made the core element that we needed to look for, improved quality of life. We also see improved social support and functioning. So consequently, more people are able to live in the community on their own. They're able to go back to work or to pursue other goals that are important to them. Next slide, please. We see reduced costs, as I mentioned before, and this comes about for a number of reasons. One is reduced hospitalizations and dramatically reduced rehospitalizations. When people are provided with peer support that begins while they're in an inpatient setting and then follows them into the community to connect them to the supports and resources in the community that they need, people are far less likely to fall back into hospitalization in that critical 30 to 90-day pattern that we often see for rehospitalization rates. Anytime we cut down inpatient days, we dramatically change the cost to the system. We also see reduced lengths of stays. People can go into hospitals now for very much shorter times than they used to. When this all started in the 70s and the 60s and even into the 80s, it was not uncommon to be in a psychiatric hospital for decades. And now it's very rare for somebody to be there more than a period of a few months, and very frequently a matter of a few weeks. Some people stay in hospitals longer, particularly as we're beginning to see a lot of people age through the system. So we have a lot of people in our behavioral health system who are aging out and who are no longer able to go back to work or don't wish to go back to work, and they need other kinds of supports in the system. We also see tremendously reduced emergency department utilization, the second most expensive, or perhaps even the most expensive type of service there is. Slide, please. So, as we were mentioning before, we're beginning to see healthier populations, and we're really just at the very edge of that, because we're just starting to look at population health through this lens of peer support and wellness and whole health. Peers are really good at engaging people who maybe in the past have been reluctant to engage in services. And the reason why they're good at engaging people in that is because they're a walking model of what can happen when you do engage in services as a full-time partner in your own services. There's also more of a focus on overall health and well-being, including other chronic health conditions. Peer support does not need to exist only within behavioral health. It's valuable to anybody who is facing serious health conditions. And eventually, we hope to see that's where peer support will go, and it will go in a way that allows it to continue to grow to, at some point, there'll be no wrongdoer. that anyone entering into a healthcare system can have access to peer support as much as they need it and when they need it. Next slide, please. So of the quadruple aim, one of the things is happier providers. So by bringing peers into the system, one of the things that we've really done is we've helped address the workforce shortage. And it's not because we're replacing roles. We're not coming in to be mini clinicians. Peer support is never clinical. It's a support role. But we are able to come into the system and provide people with easier access. When you move to a new community very frequently and you try and enroll in services, you have these long wait times to get services. Or if you're new to the overall mental health services in general or behavioral health services in general, there's these long wait times. Peers are not as constrained by those long wait times. Peers can begin seeing people early on and providing them with the appropriate amount of support that they need at that time. Peers can also do task sharing. And again, that's not sharing a clinical role. It's sharing some of the social supports type roles that we've tried to provide through community mental health over the years. And that's where case management came from, was trying to provide that social backup for people. The peers are really good at that. And as Medicaid has paid less and less for case management over the years, peer support has grown. And peer support is not case management, and it doesn't replace it. But what it does do is give people another pathway to go, perhaps an even far better pathway to go. And then we improve relationships between individuals and their providers. One of the major ways we do that is through this very simple concept. It didn't come out of behavioral health. It's throughout healthcare, but it's called shared decision making. And that's where the individual receiving services and the clinician or expert in medical type services work together as a team, because when you've got those two people together, they're both experts. The provider, the clinician, is an expert on the science and the research, and the individual is an expert on themselves and what works and what doesn't work and where they want to go in life. Next slide, please.
Awesome. Thanks, Patrick. So, as Patrick noted, and just to reiterate, the work of peers and the evolution of peer support has really, as you mentioned, humanized services, but also led and anticipated broader changes in healthcare. And I think that really speaks to the importance of not only listening to lived experience, but having people with lived experience in positions of power and decision making. And just in, another side addition, the real power that we're learning of social support is that what the research is showing is social connections are the single biggest predictor of somebody's well-being across their lifespan. So not to, exclude the just pure benefit that people get from the support from somebody with shared experience. But all of that sounds really awesome. More and more people know about peer support and are very excited by it. We see that it really changes people's lives when they have access to it. So why don't more people have access to peer support? We'll talk a little bit about the barriers to expansion, and that includes certification standards, health system knowledge, lack of knowledge and training for traditional providers, and unclear payment options. So to start with certification standards, so peer support has grown significantly, but there are inconsistent standards and requirements across the U.S. So as Patrick mentioned, more and more states pay for peer support. About 45 states have certification, or give or take, in the process of developing a state peer certification, but the requirements really range. So in some states, it's 35-hour training and a certificate of completion with no experience, all the way to 100 hours of training, 200 hours of direct work experience, letters of recommendation and examination. So we really see a large variety of standards for folks who are working in peer roles, and it can be pretty challenging for individuals looking to, or organizations looking to hire peers, to feel certain that they're getting the same level of experience and expertise no matter where they are and what they're hiring a peer to do. And that also points to something in the research as well of when we're looking at research on peer support, there's definitely differences in the training and background of the peers in that research as well. The second is health system knowledge. So health systems may have heard of peers, but they aren't sure how to integrate them and where they fit. They aren't something that health systems, even as more and more are thinking about support and services more broadly in a more holistic version or view of what people want and need. It's not something that they've been doing for a very long time. So both in public services that have been doing this a little bit more, but private and the commercial sector as well are increasingly interested in these ideas, but just don't have the background or history with it. That might be helpful. Other piece is lack of knowledge and training for traditional providers. So peers, when they're introduced in services, historically and even now, confront power dynamics about, this is the role of the clinician and this is the role of the people receiving services. And especially if you're used to working in a crisis setting where you're not used to seeing people recover and do well, and you're only used to seeing people when they're at their worst point, it can challenge some of your ideas, some of your experience, and maybe some of the things that you've been taught about what it means to be a person with lived experience with a diagnosis, how they, recover and move on with their lives, and what they can provide and offer to other people. Another thing is that professionals often don't understand the clear role of peers. So Patrick went over earlier on some of the differences in perspectives, but there's also, differences in what is within my scope of practice as a peer, what don't I do? And for professionals who don't have a clear understanding of peers and don't have any sort of training before having to work alongside peers or with peers, they can push them into clinical roles, which peers are not created to do, or other roles not related to their training. So they're neither mini clinicians, but they're also not there just to drive people to appointments or to do, any kind of office work or some of the things that we see when settings don't know what to do with peers. Peers can get shoved into kind of different roles that are not related to what they've been taught to do and the ways that they can work best. And the final piece that comes up most frequently are unclear payment options. So currently, as Patrick mentioned, peers are paid for through Medicaid, so whether that's direct billing or waivers, and also through state and local funds. Managed care organizations have been leaders in peer support expansion, but in the commercial sector and even within, folks in public health and public health systems, they're not really sure how to expand peers, where does the money come from, how does billing work, and while a lot of it is, in the context of fee-for-service, peers help improve people's lives and reduce hospitalizations, but they don't necessarily fit best in fee-for-service. They're more aligned with where we're going in healthcare financing, although they do provide plenty of benefit where things are. And I will turn it over. So those are some of the problems we see. And I'll turn it over to Patrick to discuss some of the solutions that we believe in and that we would love to work with all of you on.
So, we've talked a little bit about how good and powerful peer support is. We've also talked about some of the barriers, particularly the inconsistencies in credentialing from state to state. If we're ever going to move peer support into the full mainstream of healthcare, we have to be able to create uniform standards and expectations across the country. For instance, Medicaid, which is jointly administered by states and federal government, is able to pay for peer support in certain ways. Medicare is not. Medicare has one standard across the country. So if they're going to be paying for Medicare services in Washington State and Medicare services in Florida, they want to know that they're going to get the same quality of care. So one of the principal ways to do that is to develop national standards. And the International Association of Peer Support and SAMHSA have worked on national standards and principles for a number of years, but they've not been fully adopted by every credentialing organization in the various states. So Mental Health America has one possible solution to that, and that's the National Certified Peer Specialist certification. And this is not to replace state certification. NCPS is an advanced level certification. It's for people who have been working in the field for quite a while. It's the first national advanced peer certification, and it requires that you either be certified in your state or you have an approved MHA training, and in your state it must be a, I just lost my screen. Well, anyway, I'll go on. So you, like I said, across the country, the standards are different. But when you start to impose a standardized level across the whole top of it, now private insurance, Medicare, any type of payer can now see that, especially large healthcare systems, can see that when they move from one geographic location to another, they're going to get similar type of services. And one of the other things that the NCPS does is it really puts an emphasis on peers as part of an integrated team with whole health focus. So we're really trying to look at people in a holistic way. And that's been, you know, some states have been very, very forward thinking in this and have developed really terrific certification processes, but others have not. And so we've stuck with basically just the ABCs of basic peer support in mental health and possibly in substance use. So another solution is to provide technical assistance to health plans and health system leaders. Peer organizations, peer-run programs, and health systems working in partnership helps each other to address the other's needs. And so when a healthcare organization, for instance, a large hospital corporation, might want to bring peer support into their private system, and they've got hospitals around the country, they can work together with a peer-run program to both train and educate their existing staff about what peer support is and what it isn't, but they can also look to new ways that peer support can grow inside of these new opportunities. We'll also talk about providing technical assistance that can help organizations to figure out what part of their system can best benefit from the introduction of peer support into the system. And finally, training and support for traditional providers is important too. When peer support first comes into any system, it's a bit of an unknown, and there's always questions, and particularly questions from staff. People are worried that peers are going to replace their positions with lower paying jobs, or that they're not going to be able to adhere to the same kinds of codes of ethics and professional responsibility that any other profession does. So it's very important ahead of time that peers and people who are very familiar with the peer model be the champions within those organizations to explain this is what peer support is going to be like, so that when the peer comes to work there, and we never advise that only one peer work in an agency. It's much better if there's a minimum of at least two, because one of the things we know about ourselves, and we've learned through many, many years of experience, is that we need support too. As peer workers, we need our own support. So if we can work in a team type of situation until we become a fully integrated member of the entire healthcare team, we're much stronger. So peers are really good at coming in and helping to train the staff to be ready for it, make sure that the proper supervision models are being used. Supervision of peer support is a bit different than supervision of any other type of position, and it absolutely requires a very clear understanding of peer support, what it is, what its boundaries are, and what it doesn't do. And I think we go back to you, Kelly.
Awesome. Thanks, Patrick. And the final point on solutions to the expansion of peers, our new payment focuses and opportunities. So, of course, we support increased coverage of peers in Medicaid, expansion in the private sector, as Patrick mentioned, and Medicare as a payer who is not currently reimbursed for peer support, but would really change a lot of lives if they did. So I'm going to talk briefly about some of the MHA pilots that we've done, and very briefly on some of the broader payment structures that might be helpful for peers. So from our pilots, so we have two pilots in particular to talk about. So we did one pilot with Hospital Corporation of America using the Bridger model. So we had peers meet with individuals during inpatient psychiatric unit stays and support them back into the community. For this project, we worked with ourselves and our local affiliate to employ the peers. And the funding came from a combination of a grant from the National HCA organization and the hospital. So they paid directly for the services that saved them from things like high rehospitalization rates that they could otherwise get penalized for. We also did a contracted pilot with Kaiser Permanente's health system in Northern California. We worked with folks as part of integrated care teams, helping people address some of their broader well-being and health concerns, including providing peer support. And these were folks with comorbid mental health and chronic health concerns. And that used funding from their Internal Care Management Institute for creative models to look at some new ways, and ended up saving them a significant amount of money and improving outcomes such that what started as a two-person pilot has now become an 8-person or 8-peer team within the organization. And one of the other options that we have been working on is working with treatment centers to contract with us on adding peer support to what they're already providing, and then having health plans to support the use of peers to reimburse at a higher rate for the peer services that are included in what they're already doing. But so far in our pilots, the funds were not being paid out of plan dollars, but out of pilot money or grant money, specifically testing what we've been doing. And as I mentioned earlier, you know, peer support certainly can fit into fee-for-service, which is where it's been used a lot, but is really, really primed to fit well into ways that we're restructuring restructuring healthcare financing. So last month we did a webinar on peers and alternative payment models. It looked at alternative payment models, so changes in how we pay for and incentivize services to give people financial rewards for doing a good job, and sometimes penalize them for not performing. So giving people a sum of money to use in certain ways that isn't as prescriptive as we only pay you for doing this one thing, but more looking at what are your overall goals, what are your outcomes, and giving you, supporting you, or not supporting you based on how you do that. And three specific models that we covered were population-based payment models, which really look at per month per member payments to providers or teams to manage the health of a specific population. And peers fit really well in here because they have an emphasis on coordination and effectiveness while producing inpatient and emergency services. So they're based on cost, provider performance, and can be shared based on how that goes. The second type of APM that we included was episode-based payment models. So they offer payments based on specific health events or conditions. And then those, again, are decided on expected costs. The final model we looked at was social determinants of health model, which is more about reimbursing based on a comprehensive view of people. So looking at providing services for coordinating and offering broader things that are not traditional healthcare needs like housing and transportation, and offering partnerships with community-based organizations. Sorry about that for you all. It looks like some folks had some difficulty hearing me, so I apologize. We do have additional, more in-depth information about peers and APMs. It's a pretty complicated topic. You know, we wanted to do a quick 60-minute introduction, and I'm happy to share that directly with you, or you can find it on MHA's website. But really, just to summarize, peer support can help us improve outcomes, reduce costs, and reach more people, and improve the lives of providers. So things that peers have been working on for decades are really mirroring what healthcare in general and healthcare financing is moving towards. And partnering with organizations like MHA and the NCPS can provide upfront and ongoing strategies to create the best outcomes for all. So you know the value of peer support, but it's important to offer support to different organizations that might be new to peer support on how to best integrate and implement it.
So I just wanted to add a couple of things. First, I'd really like to apologize for the technical difficulties. I don't know if some of you lost your connection as I did before, and also with the audio problems that we've been having. But this is all going to be followed up in much more detail in our upcoming series of webinars on these subjects. So we're really excited about bringing this information. This was just really here to give you kind of a taste of what our viewpoint is on peer support and where it's going, and we're going to get very much more in depth than that. And now Kelly's going to talk to you about some of these upcoming webinars.
Yep. Thanks, Patrick. Sorry for folks, again, for the technology cutting out. Wanted to talk about 2 upcoming learning sessions we have for healthcare leaders. So the first is Employing Peers 101, and that's going to be on April 17th from 12 p.m. to 5 p.m. Eastern Time. And it's a 5-hour intensive session. You'll learn where peers fit, how to prepare your organization for peers, and how to hire and supervise peer specialists. And the second is Peer Support for Payers and Health Systems on April 19th from 12 p.m. to 5 p.m. Eastern Time to learn about the cost and quality improvements that peers provide, how to measure them, and the best settings for peers in the populations that you serve. And these were designed, you know, there's a lot of information out there about the benefits of peer support. These are really designed to be in-depth information sessions, but also discussions where we can work directly with you to find the best way to integrate peers, whether you're looking to just hire peers or trying to enhance what you're already doing, or more broadly are looking for where peers fit within your organization or health system, or how to pay for them. And we do have 4 minutes left for questions. So the first question we saw was, state-to-state transfer of certification isn't supported really either. Yes. Patrick, do you want to take that one?
Well, that's true. There's, you know, in professions, there's very often where a state has a credential, it will have a reciprocity agreement with another state so that you can transfer your credentials from one state to another. Peer support hasn't gotten there yet. And again, the main reason for that is because we have this unevenness of standards across the country. A few states are banding together and offering reciprocity, but I think as we move more into these national standards and national skill sets and principles, we'll find that this becomes a much easier transition. And I think the future for peer support is that we are evolving into a full-fledged profession. Not a clinical profession, but a profession nonetheless, in that we have specific knowledge that comes from training and experience. And so as we do that, these barriers, I think, will begin to fall, and people will have the ability to carry their credential from state to state.
Awesome. So some folks have been asking questions about webinar recordings. So this session and then all of MHA's broader webinars and our Center for Peer Support webinars are recorded, and posted on the MHA website. I will also send this recording to all of the folks who've registered, so you'll have the recording and the slides available within the next couple of days. The 5-hour sessions won't be recorded, and there is a fee. Folks can reach out to me directly about discounts if they're available. But sorry about that. But the 5-hour trainings are really supposed to be more of a discussion and workshop with folks. So we didn't want to have those, publicly available to give people time to really talk about what they're experiencing and to ask their questions. Let's see.
So do you have any more questions?
Yes. So we have a couple minutes. There's a question, is there a list of Medicaid reimbursement for peers by state? There are a few documents out there that go over who pays for peers in Medicaid, but I can also send you directly a list of what we've been able to gather about reimbursement under Medicaid for peers across the states. Let's see.
And I would add to that, this is also one of the issues that we faced in trying to have, credentials travel from state to state, and it's the unevenness of the way that peer support is paid for when you go from state to state. Medicaid is a complex system. Much of peer support in the past has been paid for through waivers. Things are beginning to change now, and as we begin to get rid of these bumps in the road, I think we'll really be ready to grow as a full-fledged profession.
Okay. Thanks, Patrick. So Casey asks, is the NCPS currently Medicare reimbursable? So the NCPS is not currently Medicare reimbursable, but that is something that we're working on through our national office, through our federal strategy. So there's been indication that Medicare is interested in peer support. They put out a notice on peer support as an alternative to opioids for pain management. So there's definitely indication they're interested, and that's something that we're working on, but not at this point. Let's see. Is there a specific place online or physically that I could go for learning how to become a peer specialist in Michigan? So through our Center for Peer Support Online, we do have information about how to get started as a peer specialist. I would also refer you to the SAMHSA Technical Assistance Center Doors to Wellbeing that tracks all of the different certification processes and requirements by state, and they can help you find specific contacts and resources for Michigan and then any other states that you are in. And then Darlene asked, the NCPS is 3,000 hours. That's 1.5 years full-time job, correct? Yes, that is. So 3,000 hours, 1.5 years of full-time experience is the experience level requirement for the NCPS.
And I'd like to add to that, Kelly, that's not necessarily that you have to have worked 1.5 years full-time. It's 3,000 hours over, I believe it's 6 years of experience.
Yes, and to add to that as well, it doesn't have to be, it can be volunteer experience, paid experience, or a combination of the two. We just need to be able to verify the experience. So it looks like we're slightly over. Let me see if there's any last questions. Awesome. Okay, well, thank you all so much for joining us today. On the screen now, you'll have access to Patrick and my email addresses, so just first initial last name at mentalhealthamerica.net. We're happy to answer any additional questions for you, share any information, and we would love to see you all for our 2 upcoming sessions in April. And thank you again for joining us today. Patrick, I don't know if you had any outgoing or closing messages for everyone.
No, just thank you for your patience, and hopefully we'll have a much more stable platform for the next ones. Thanks.
So thanks, everyone. Have a great day.